anesthesiologist. طيب انا كده اتسربعت، انا حاسس كده انا مش عارف اتكلم. طيب اوكي. Today we are going to focus in Mufid. We are going to focus on infection in ICU, and we usually look for bacterial, for other type of infections, but in Egypt we are not focusing on fungal infection, which is quite important for us. So I will tell you the efforts in different liver transplant centers, ending by our Menoufiya University Liver Transplant Center. This is our new liver institute, which is about now 400-bedded institute. And this is our OR. It is well-equipped OR with up-to-date equipments. Serious fungal infection, I just came across this article in 2017 talking about a high percentage of fungal infection. They stated it to be about 2% of the Egyptian population. And it was published in the European Journal. It is a joint research work between Ain Shams University and Manchester. So, as we know, that systemic fungal infection is quite important in organ transplants. Organ transplants ranks number 3 among the candidates who are susceptible to infection. If you look at the epidemiology in the States, we can find that Candida albicans looks for about 54%. Infection is the most serious complication in organ transplant, and the most important thing is blood transfusion. So if I give a lot of blood transfusion as an anesthetist or as an intensivist, my patient will be more subjected to fungal infection. The incidence of fungal infection in Egypt has been studied in several institutes, and it was ranked as number 5 or 4 in the intensive care. Candida infections is number 4. So I want really to focus in our meeting here is that fungal infection deserves attention in our intensive care units. And where it comes from CVP lines, from ventilators, from invasive maneuvers. Infection complications and pattern of bacterial resistance in live donors have been studied in Cairo University by Ahmed Mukhtar and other colleagues, and they found that 52% developed infectious complications, and biliary tract infection is on the top of them. A retrospective study was done in Cairo, and that was very important, published in 2014, and it demonstrated that fungal infections in liver transplant patients has a significant, it develops mainly at the 2nd month. So it is not immediately post-operative, but I will show you results from our institute. In 43% of them are invasive fungal infection. So we are fighting for our patient to survive liver transplant, but we are not fighting for him to survive fungal infection. We have to be aware as intensivists, hepatologists, that fungal infection is a real and serious risk in our intensive cares. Fungal infection was studied in Asyut University, and they found risk factors for it, like history of antibiotic use, high MELD score, hepatorenal syndrome, and that the most serious problem is delayed diagnosis and treatment because it carries high fatality. The high risk factors of fungal infection in live donors was also assessed in Tokyo, and they found independent factors for it, like reoperation, post-transplant dialysis, and bacterial infection. Risk factors was studied by Tanaka, Koichi Tanaka. He's a Japanese surgeon who comes in infrequent visits to our institute as well. Epidemiology was also studied in our liver institute, but not in liver transplant. It was studied in hepatopancreatic biliary surgery by Wissam Murad, and she found high incidence of fungal infection. There's a lot of guidelines, but the latest is the guideline by the EDISA, candidiasis in 2016, and they say that we could use the fluconazole for most of the patients, but if you have non-neutropenic patients with candidemia, you should start with the recent and important drugs, echinocandins. We have 2 echinocandins drugs now available in Egypt. We have micamine, mucofungin, and anadilofung. Both of them are now available in our intensive care in Menoufiya University. So we should start with echinocandins first and then go down to fluconazole. So if you have them neutropenic, you do the same. And what is the recommended duration? So if I diagnose candidemia in one of my patients, the recommended time for treatment is 2 weeks until it is cleared from the blood. Most of them are now talking about start with strong antifungal drugs like echinocandins, then go down to fluconazole. Am I going back? I think I'm going back. Okay. So that's it. So what is the role of empiric treatment of suspected candidiasis in non-neutropenic patients in intensive care? Yes, it is strongly recommended and with moderate quality evidence. And all of them recommend starting with strong antifungals. Aspergillosis is another important issue that should be highlighted and intensivists should be aware of. We've lost one of our patients in our institute from invasive aspergillosis. Until we started to have good communications with our microbiology department to know that we should hit the aspergillosis with voriconazole, and we should look for halocyan to diagnose it actually on the CT scan. And this is the halocyan. And it is formed from a necrotic, coagulation necrotic area, and around it a hemorrhage. So if you could pick up this early enough, because early diagnosis will differ a lot. If you have a halocyan, this really indicates that your patient is developing invasive aspergillosis. So what is the right treatment for invasive aspergillosis is voriconazole. This is the right drug. This is the drug that's going to treat it. So if you don't diagnose, you will not know the patient will go exactly into invasive aspergillosis, which carries a very high mortality rate. So VFEND or voriconazole is approved for the first-line treatment of clinically important fungal infections. Echinocandins as antifungal prophylaxis in liver transplant has been visited. The main line is to use fluconazole, but 2 studies started looking at mecanofungin appeared to be associated with lower early renal dysfunction and no additional risk of hepatic dysfunction. Another study was done in Europe called 10-pin study, and it looked into the use invasive of mecanofungin as first line of prophylactic treatment in liver transplant patients, and they found that it was a non-inferior to the standard treatment, but it had better kidney functions with mecanofungin. But you have actually to start with fluconazole and then go to mecanofungin. In another randomized double study, the incidence of invasive fungal infection was similar with anaesthesia and fluconazole. This is a study from our department of Anaesthesia and Intensive Care in Menoufiya. We're going to present it next month in the European Society. We are trying to compare mecanofungin compared to fluconazole for prophylaxis in high-risk live donor liver transplant in a randomized control study. We found that mecanofungin has a reduced effect on renal and hepatic graft functions compared to fluconazole. Termination of the mecanofungin after discharge from intensive care led to positive cases of invasive fungal infection. And we should continue prophylactic antifungal to beyond the 5 days of the intensive care. We did not find a great difference between using mecanofungin and fluconazole. So in only high-risk liver transplant patients, we would recommend in the presence of candidemia to use mecanofungin as a prophylactic measure. Because, I only have 3 slides left, because mecanofungin and anaesthesia, these are very expensive drugs. We should leave them for resistant strains or very susceptible and high-risk patients. Nowadays, in 2017, just few months ago, the first resistant strain to mecanofungin and echinocandins appeared in a study from France. And this is the fear that we might develop resistant strains to fungal if we misuse the expensive new agents, antifungal agents. They found 3 mutations for Candida glabrata and 1 mutation for other candidiasis. This is the first study on echinocandins resistance in Candida in liver transplant population. Most resistant isolates were found in the digestive system site, perhaps due to the low diffusion, This work documents the risk of emergence of resistant strains to the new drugs from the echinocandin group. We have another MS thesis running in Menoufiya University. We're looking at mapping all our liver transplant patients for fungal infection and to improve our communications with the microbiology department. And we use high-tech equipments like Vitec, which will be able in less than 4 to 6 hours to diagnose the type of fungal infection. Thank you very much.
Thank you very much, Professor Khaled. It's, you can say it's professional presentation. You were in time, actually. Thank you.